dermatology is one of the important topics from MRCP because the questions that will gonna be there, like there will be only 4 or 5 questions from dermatology, but their weightage is very high. Okay, the total percentage in the total score, it will be high because you are only doing it with. Hello.
Yes, sir. Now it's back.
Hello.
Okay. I'm sorry. I think my connection was uh, having some problem. Anyways, so guys, let's start with the dermatology. So the first topic of dermatology is hereditary hemorrhagic telangiectasias. So guys, in dermatology, things are interesting and easy. Okay, if you know that what exactly you are looking for, same catching point, same important words you have to look for in the statements, and your life will be very easy. So just focus on these things, and dermatology will be very easy topic. So how you will gonna get a question? The most favorite question that you will gonna get is this, guys: autosomal dominant. They will gonna ask you, patient having the hereditary hemorrhagic telangiectasia, what is the inheritance pattern? Autosomal dominant. The other important thing is that you have to know that in hemorrhagic telangiectasias, hereditary hemorrhagic telangiectasias, and please don't forget to remember the other name. I am always stressing on these things that maybe they will not gonna give you this name because it's a common one. They will gonna give you this name to confuse you. So don't ignore the alternative name of any of the disease. Okay. Then the next thing that you have to focus more on is how the patient is gonna present. So guys, everywhere from the body there will be either bleeding, or there will be telangiectasias. Okay, anything you're gonna get a question that a patient has presented to you with multiple telangiectasias on his lips or oral cavity, finger, nose, along with recurrent epistaxis, and he has presented with hematemesis. So the patient is having which of the following condition? Okay, so guys, telangiectasias, bleeding, AV malformations, these are all the characteristics of hereditary hemorrhagic telangiectasia. So, and there will also be a family history, remember it. The important thing I told you, this is the most important thing you will gonna get. Their favorite question. Then, eczema, guys, eczema. Okay, we will gonna read in details about eczema later on, but the important thing here is this table. It is very important because they will gonna ask you about different strengths of different steroids, guys. There are mild, moderate, potent, and very potent. You have to memorize the name. You have to memorize the strength, guys. Okay, you have to memorize it because they will gonna ask you that which of the following is a moderate dose steroid, topical steroid. They will gonna give you this, and this. Okay, and this one will be there, or either this one will be there, and you have to select this one. Similarly, very potent, all of them will be there, and this will also be there, so you have to select this one. That's how. And remember this, they will gonna make the question tough. Maybe you will gonna remember the names, but the problem will be this one: dosage. As you can see that that colbistol propionate 0.05% here. Okay, here it is colbistone butyrate 0.05%. This is how it will get confusing, guys. You have to remember that butyrate is moderate, whereas propionate is very potent. Okay, similarly you can see that here beta-methasone valrate is 0.05%, where here it is 0.1%. So this is how things are gonna get complicated. Okay, then this is, you just have to go through it. No need to remember all of this thing. It's not that important. Similarly, just go through this table. These are not important. I haven't seen questions coming from it, but you, nobody knows that what they're gonna give you. But the thing is that just go through this table. Okay, it is actually, they have written you that if there is any if there is any lesion on the and you have to apply steroids on hands, this is how much dose you will gonna use. If it is entire arm and hand, this is how you. Fingertip unit is FFU, guys. Sorry, fingertip unit is FTU. It means that you have to apply 4 fingertips unit if it is entire arm and hand involved in eczema. Okay, this is how the question can come. Similarly, this is the amount in grams. Okay. Okay, so the next question is the next topic is pamphylix, guys. It's a very important topic. How you will gonna get a question? You will gonna get a question that a guy presented to you with complaint of itchy papular lesions on his palms and sole, very itchy. Okay, and patient will be working maybe in some patient will be working in conditions with hot and humid condition, guys. It is more in hot and humidity. Okay, the typical point will be small blister on palms and sole, very itchy, very itchy. Okay, and there can be also some what you call it, the blister can burst and the skin can be dry or crack as well. So how you will gonna manage? Cold compresses, emollients, and topical steroids. Okay, this is how you're gonna get the question. Next is nickel dermatitis. Okay, they will gonna ask you what type of hypersensitivity reaction is this. You have to answer it's a type 4, and more common with jewelry, which is watches, maybe bracelets, something like that. And we have already read that it skin patch test is used for dermatitis of the skin. So this is what they will going to ask you: skin patch test and hypersensitivity reaction. Then antihistamines are the treatment option in allergic reaction and urticaria, guys. Remember it. Remember it. Then the question will be, which of the following is a sedating antihistamine? Chlorpheniramine. Okay. Then antihistamine, anti-muscarinic properties they will also be having: urinary retention, dry mouth. Which of the following are the non-sedating antihistamines? They will going to ask you: loratadine and cetirizine, guys. Remember these things. Sedating, non-sedating. This is how you will going to get a question. Then psoriasis. Next important topic is psoriasis, guys. So psoriasis is they will gonna ask you about different things in the psoriasis. First of all, they can ask you about the genetic disposition, HLA association. Then they will gonna ask you about this strong concordance, 70% in identical twins. Okay. Then this is the mechanism, pathophysiology, guys. Abnormal T cell activity. This is very favorite question. T cell activity. They're gonna give you B cell activity, lymphoblastic, neutropenic activity, T cell activity. So guys, psoriasis is because of the abnormal T cell activity. Then this will gonna produce interleukin 17, guys. You have to remember this. You have to remember this, guys. Then the second important thing is this: exacerbating factors, guys. They will gonna give you a question. A patient is a known case of ischemic heart disease, recently diagnosed or known case of ischemic heart disease, and he has been started on a medication. After starting the medication, the patient's condition, the psoriasis has exacerbated. Which medication has been started? Guys, it will be either beta blocker or ACE inhibitors, guys. This is how you will gonna get a question from it. A patient is a diagnosed case of psoriasis, but his psoriasis is controlled. And recently he has a myocardial infarction and he was treated. He came home after 1 week. His psoriasis has exacerbated, which is the reason for it. So guys, it will be either beta blocker or ACE inhibitor. Similarly, if it will be, they will gonna tell you a patient is having a bipolar disorder. Which medication has been started? Lithium, guys. Antimalarial, NSAIDs, infliximab. These are all the exacerbating factor. And always remember, guys, streptococcus infection is one of the commonest cause of exacerbation of psoriasis. Streptococcus infection, guys. Streptococcus infection. This is how you're gonna get a question. Then there are different types of psoriasis, guys: plaque psoriasis, flexural psoriasis, guttate psoriasis, and pustular psoriasis, guys. Okay, so you have to go through this table and you have to remember that what exactly does it mean. Is that plaque psoriasis is most common subtype. Okay, red scaly patches will be there, okay, on the extensor surface of the sacrum or scalp. Flexure will be more common in the flexure region, like underarms, under the legs, okay, between the legs, these flexure areas. Then this one is important, okay, date psoriasis. It is a psoriatic rash more commonly caused by streptococcal infection. Multiple red teardrop lesions, guys. Teardrop lesions. This will be the typical uh, catching point in the that will be there in the question. Teardrop lesions, multiple red teardrop lesions on the body, guys. Okay. Then pustular psoriasis, less common, and it is common on the palms and so. Okay, the common question will be this, and this. Then management is very important, guys. Remember, it is for the plague psoriasis. What exactly we have to do? First of all, what you have to do is that advise regular emollients. Okay, what it will do? Decrease the scale formation, and it will gonna prevent the pruritus. Then first line of medication you will gonna do to the patient is potent steroids plus vitamin D. And remember, you have to apply it separately, guys. One will be in the morning, other will be in the evening. Remember it. Okay. Then, if the patient is not getting better with this, after 8 weeks, what you have to do is that you have to apply vitamin D 2 times. Vitamin D 2 times. Skip steroids and start vitamin D 2 times. Remember, here it is OD, here it is BD. Then, third is if no improvement after 8 to 12 weeks, you have to start the potent steroids 2 times for 4 weeks, or coal tar preparation 1 or 2 daily. This is the line of management for the patient of psoriasis. What will be the first line? What will be the second line? What will be the third line? You will going to get a question that first line patient was started on potent steroids OD and vitamin D OD. What his symptoms are not getting control. What you will going to do next? What you will going to do next is that you have to wait for 8 weeks, and then after that you have to start the patient on vitamin D BD. Or if still not, then you have to wait for 8 to 12 weeks to see the results. Okay, here it is 8 weeks, here it is 12 to 8 to 12 weeks. Remember it, guys, remember it. Then if still not, then you can go to BD, potent steroids, or this coal tar preparation, guys. Okay, now how you will gonna use the steroids in patient of psoriasis, guys? Remember that steroids have side effects. Okay, they can cause atrophy, strias, rebound symptoms. Systemic steroids can also cause a lot of different problems. Then this is very important. 4-week break before starting another course of topical steroid, guys. Remember it. 4 week. If you have given steroids, you have to wait for 1 month, 4 weeks to give the topical steroids again. You cannot give because it will gonna cause the side effects. Then potent steroids less than 8 weeks a time, whereas a very potent corticosteroid less than 4 weeks a time. Remember it. Remember it, guys. That's why I told you that table of potent, very potent are, you have to remember the name, because they will gonna give you the name. They will not gonna give you very potent steroids. They will gonna give you the name, and they will gonna ask you how much time you are able to use this steroid. Either it will be a potent or it will be a very potent. You have to remember the name. Then only you will gonna answer. If it is potent steroid, it is less than 8 weeks. If it is very potent, it is less than 4 weeks. This is how they will gonna ask you the question. Then vitamin D we are giving to the patient. So you should remember that vitamin D analogs can be calcipotriol, okay, or calcitriol or tacalcitrol. So what exactly is the mechanism behind their action? Mechanism of action, guys, this is important. The mechanism of action is that they decrease the cell division and differentiation. This is what they will going to ask you. You are giving a patient of psoriasis with vitamin D, okay, So what is the mechanism behind it? The mechanism is that it will gonna decrease the cell division and differentiation, which results in the scale formation and plaque formations. This is the mechanism behind it. You have to remember it. Then, um, avoid in pregnancy. You cannot give it in pregnancy, guys. And maximum weekly dose of adult 100 gram. Then the next thing is that, guys, topical steroids are commonly used in flexural psoriasis and mild steroids in facial psoriasis. This is a very, very important line, guys. Mild steroid, they will gonna ask you, a patient has been diagnosed with facial psoriasis. Which of the following medication you will gonna start? There will be mild steroids given, the name hydrocortisone, mild steroid. Then there will be very potent like that. Okay, so you have to select the mild steroid, guys. You have to select the mild steroid, guys. You have to select the mild steroid. Remember, this is how you will gonna get the question. Mild steroid, I have told you, mild steroid is hydrocortisone. Moderate are these, potent are these, very potent are these. You have to remember the name because they will gonna give you the name. Then scalp psoriasis, guys. Scalp psoriasis. You have to use steroids. Okay, no improvement. You can use different formulation of potent steroid shampoos. Okay, topical agents to remove adherent scales, salicylic acid. This one, just read it. Just read this. This one is important. Otherwise, other things are just to read for you guys. And we have already read that face flexural mild are used on the face. Moderate can be used in the flexural region. Applied 1 to 2 maximum for 2 weeks, not more than that. And you cannot apply vitamin D in the flexural region because it is irritant. Remember, they were going to ask you, topical calcipotriol is not used in flexural or face or genital psoriasis because it is irritant, guys. It is irritant. Then what is the next step if these things are not going to work? Phototherapy, guys. And remember, their favorite question is B light. They're going to give you A light, B light, gamma light, alpha light. So you have to select B light, guys. B light 3 times a week. Then the other thing is photochemotherapy, which you can use with personal and a ultraviolet A light. Ultraviolet A light. Here it is A light, guys. But here in a phototherapy, only it is B light. But if it is photochemotherapy, then you have to give this with A light. What are the side effects? Aging and squamous cell carcinoma. Remember it. Aging or squamous. They're gonna tell you a patient is on uncontrolled psoriasis and he is undergoing phototherapy. Which of the following is the side effects? Guys, squamous cell carcinoma. Or which of the following is the patient more prone to? Basal cell carcinoma, squamous cell carcinoma, rhabdomyosarcoma, something like that. So the answer will be squamous cell carcinoma, guys. This is how you will gonna be assessed on this. Then we have already read about the psoriatic arthropathy in rheumatology, and we know that the treatment for that is this one. This is what I already told you, that whenever you're going to start about intercept and tumor necrosis factor, TB is the one that should be ruled out. Then this one, guys, adalimumab, these are the monoclonal antibodies. Okay, it can be used, and the mechanism of action should be this: interleukin 12, interleukin 23 blockers. Remember it, guys. Remember it. And this is the overall in the summary for the mechanism of actions of the drugs. Coal tar, they inhibit the DNA synthesis. Dietronol decrease the DNA synthesis. Okay. Side effect, burning and staining. Vitamin D decrease proliferation and restore the normal horn layer. Then we have chronic plaque psoriasis, guys. Okay, it is being repeated again. I'm not gonna repeat everything again. It is just being repeated again. Plaque psoriasis, we have already read about the treatment. So this is the same emollient. First you have to give steroids plus vitamin D analog, then you have to give on vitamin D. Then third line is topical steroids twice daily and 4 weekly. This is, you can, just to make you make things clear and easy for you to revise again. That is what it is. And this is the same topical steroid therapy may lead to atrophy. It is being repeated again. Okay, so you don't have to worry that how I'm skipping it, because we have already read this above. What should I do? It's just being the repetition. Flag, flexure, we have read all of this. Okay, next thing is, guys, acanthosis nigrans. How you will gonna get a question from this? You will gonna get the question that a patient, all the history will be of POCs, polycystic ovarian syndrome, guys. Here's his hirsutism, meaning like hair on the face, acne, obesity. Okay, and they were gonna ask you that there is a brown velvety rash on the neck. What is the diagnosis? Acanthosis nigrans, guys. They're gonna give you a patient with diabetes has this rash. What is the diagnosis? Acanthosis nigrans. You have to remember the conditions. They were gonna ask you which of the following condition is not associated with acanthosis nigrans. They were gonna give you each of these. Maybe they were gonna give Addison's disease, which is not, or they can give you all other, and they will gonna give you Cushing or GIT cancer, mostly gastric cancer. This is how you're gonna get a question from here, guys. These are all the causes for acanthosis nigrans. So what is the pathophysiology, guys? The pathophysiology is that this is important because you will gonna be assessed on it. There will be insulin resistance. Because of the insulin resistance, there will be hyperinsulinemia. Okay, which will gonna increase keratinocytes and dermal fibroblast proliferation. Okay, because of this, there will be this velvety rash over the flexure areas, over the neck, and over the armpits. Then alopecia, guys. Alopecias can be of two types: scarring and non-scarring. Okay, this is their very favorite question. They're gonna give you that which of the following is not a condition cause of scarring alopecia, which of the following is not a cause of non-scarring alopecia. So you have to memorize it by heart, guys, that which of these cause scarring, which of these is not responsible for scarring. So they were going to be asked like that. Remember it, you will going to be asked like that. This is how you're going to get the question from this table. Then okay, next question, next topic is alopecia areata, guys. What exactly is alopecia areata? How you will gonna get a question from it? Let me tell you. So guys, how you will gonna get a question from this is that you will gonna be told that a patient has presented to you with hair loss. Okay, the important thing that you will gonna be told is that there is well demarcated patch of hair loss, and at the edge of the hair loss there is small broken exclamation mark here. Very typical of alopecia areata. This is what you will gonna get, guys. Small broken, wherever you see exclamation mark like small broken hair, just it is just you know, exclamation mark, we know this thing, right? So the hair will be like that at the end of the broken small hair. So just remember it. Whenever you see this word, select alopecia areata, guys. Then, what is the treatment option? Waiting. Waiting is the treatment option, guys. Waiting. Hair will gonna regrow in 50% of the patient. Remember it. They will gonna ask you what is the treat. They will gonna give you a whole scenario, and they will gonna ask you what is the treatment option. So please do not select anything. Only select reassurance or observation. Okay, because hair will gonna regrow 50% of the patient by 1 year. Okay, and 80 to 90% eventually. Okay, but if they will gonna tell you that observation has been done and hair are not still coming out, or the patient still have alopecia, then you have these treatment options, guys: topical steroids, minoxidil, phototherapy, dantrol, Tronol, and immunotherapy and wigs. But mostly you will gonna be asked question about this spontaneous remission. So remember it: well demarcated, with exclamation mark and spontaneous remission. Don't have to think anymore. Just write alopecia areata. Similarly, guys, hirsutism and hypertrichosis, guys. Hirsutism is because of androgens, whereas hypertrichosis is androgens independent. Independent, like they are not dependent and they are not because of the androgen. So this is what they were gonna ask you guys. Which of the following is a reason of hirsutism? Which of the following is a cause of hypertrichosis? So they were gonna give you minoxidil, rest will be this, or they're going to give you congenital hypertrichosis or congenital uginosis, you will going to have to select this. Or if they have told you hirsutism, they will going to give you Cushing, and the rest will be this. So guys, this is how you have to remember. Similarly, these are the continuation of that: obesity, drug, phenytoin, corticosteroids, and then here porphyria cutanea tarda and anorexia nervosa. You, when you are gonna read it, you will gonna, it's common sense. You will gonna see that the drugs are not androgen dependent. Similarly, this porphyria is not androgen dependent. Anorexia is not androgen dependent. Whereas these things, obesity, they are all androgen dependent, guys. And this one you have to remember, guys. Ferryman Galway's scoring system is used for the assessment of hirsutism. I told you in the start while we were reading hematology and cardiology, that there are certain scoring systems which they were going to ask you. Like we have read about different scoring, Grace scoring system, TIMI scoring system in cardiology. Then we Waterloo score for the bed sores. Similarly, this scoring, Freeman's Galway, you have to remember the name. It is used for the hirsutism, assessment of hirsutism. Then, what is the management of hirsutism? The best management for the hirsutism, because in a patient with androgen dependent and especially polycystic ovarian, guys, weight loss. Weight loss. Then there are different options you can use for that. Okay, so you have to just remember them. You have to remember them. You have to memorize them. Nothing to tell you more about that. You just have to remember that these are the other options that you can go for. Then we have acne vulgaris. Okay, so guys, how you will gonna get a question from acne vulgaris? First of all, the question will be that it is on the neck, face, and upper trunk. Okay, typical lesions will be comedones and pustules. They can ask you what are the typical lesions for that. Then the important thing is that they were going to ask you this percentage: 80 to 90% of the teenagers, because they were going to give you which of the following is correct about acne vulgaris. All the statements will going to be wrong. The only statement that will be right is this one: 80 to 90% of teenagers have acne vulgaris. Then what is the pathophysiology? Pathophysiology is, we all know about acne, is that obstruction of the pilosebaceous follicle. Because of this obstruction, there is this acne formation, and there is a bacteria called Propionibacterium acne, which cause inflammation, and because of this it happens. So this classification is important because they were going to ask you that a patient is having open and closed comedones and sparse inflammation lesion. Which of the following acne is it? Mild, moderate, severe, moderate to severe. Then either they were going to ask you widespread non-inflammatory lesion plus increased papules and pustules. Severe, extensive inflammation with nodules, pitting, and scarring. This is called severe, guys. You have to memorize it because the treatment also depends upon mild, moderate, and severe. So please remember it. Then, guys, what you can do is that you can start the patient with topical retinoids. Okay, then you can either give combination of retinoids or antibiotics or benzyl peroxide. Then they will gonna ask you which of the following antibiotic is used in acne vulgaris. Guys, it's tetracycline. Tetracyclines, doxycycline. Then they will gonna ask you, a lady is pregnant or breastfeeding, so please avoid tetracycline and give erythromycin. This is how they will gonna ask you questions. Lady is pregnant, now you have to give the antibiotic, erythromycin will be used. Then next thing they will gonna give you is this one, minocycline, guys. Less appropriate, possibility of irreversible pigmentation. This is its side effect. Remember it. Minocycline cause pigmentation. They were gonna give you that a patient with acne vulgaris had been started on minocycline, and he has been given and he develops a patient has been patient is a known case or patient has been diagnosed with acne vulgaris and a medication was given. After that, he developed pigmentation. Which of the following medication has been started? Guys, this is the minocycline that has been started. Minocycline can also cause one else we have already studied in rheumatology. Can anyone please tell me if someone, if anyone can remember what exactly minocycline can cause?
Drug-induced lupus.
Excellent, excellent. Drug-induced lupus, guys. Drug-induced lupus. Very good. Then this is how they will gonna mix the questions, guys. They will gonna give you a scenario of acne vulgaris. They will gonna tell you minocycline has been started, or they will not gonna tell you and they will gonna tell you a patient has developed a rash on his face and anti-histone antibodies are positive. So what is it? So guys, minocycline has been started because of which the patient has developed drug-induced lupus. This is how they will gonna ask you questions by interrelating different topics. Then okay, a single oral antibiotic for 3 months. Then, uh, topical retinoids, if not and or benzyl, co-prescribed with antibiotic in decrease the resistance development. So it's better to prescribe the topical with the oral antibiotics. Then, guys, the other important thing I want to tell you in this is that okay, this one, guys, this is very important. You have to remember that retinoids, which are oral isotretinoin, it is used only under the specialist supervision, and it is only used in severe acne, guys. They're gonna ask you that they're gonna give you this thing, guys, the classification. They're gonna give you the classification that a patient has comedones, inflammation, nodules, pitting, and scarring. It is severe. So what is your treatment option, guys? The treatment option for severe acne is retinoids. This is how you're gonna get a question. Is that clear?
Yes, sir.
Yes.
Great. Then
Yes, sir.
adverse effects, guys. Tretinoin's adverse effect, a lot of adverse effect of tretinoin. Okay, that's why it should be used under specialist. It is teratogenic. Teratogenic. It is so much teratogenic that the patient should use 2 forms of contraceptions. 2 forms, both. It is that much teratogenic. Then dryness of the lip, eye, nose, and the lips. And the most common side effect, bleeding because of the crusting, cause of dryness and crusting in the nasal mucosa. There will be nasal bleed. Patient can have low mood, depression, another psychiatric problems. Remember it. It can also increase triglycerides level. Remember it. Then hair thinning will also be one of the reason for isotretinoin. Intracranial hypertension is also another what you call it side effect. So isotretinoin should not be combined with tetracycline for this reason, guys. Guys, this is what you will gonna get a question. They have already told you that isotretinoin and doxycycline can cause this. So guys, they're gonna give you a scenario and they're gonna give you that a patient is on isotretinoin for severe acne. He developed maybe some STI, okay, sexually transmitted infection, chlamydia, and he was started on doxycycline. After starting doxycycline, patient developed headache, urinary incontinence, all the feature of intracranial hypertension. Then they were going to ask you which of the following is the diagnosis. So guys, this is how they correlate questions. Now, the question they have created is of CNS, neurology, but they have also assessed you on isotretinoin and doxycycline, dermatology. So isotretinoin should not be and doxycycline can also be, you know, in STIs, chlamydia. You can give doxycycline PD for 7 days, but the thing is, what is the purpose of telling you whole story is that this is how they correlate question, and candidates get confused because they haven't studied like that. They will gonna keep neurology separate, they will gonna keep dermatology separate in their mind. You have to correlate things, guys. You have to correlate. Okay, if you have read something in somewhere else, try to recall it, that what was it that I have read in neurology, intracranial hypertension. So I have to remember that if a scenario comes that the patient is taking isotretinoin and doxycycline for any reason has been added to the treatment. So the thing that can happen is intracranial hypertension, raised intracranial hypertension. That is how you will be assessed. Then there is no role of dietary modification, guys. No role of dietary modification. Next topic is acne rosacea. And the question that you will going to get from this is that a patient is having flushing erythema and telangiectasias of the face, okay, and papule and pustules, then mostly on the nose, cheek, and forehead area. Flushing is the first symptom. This is their favorite question. Which of the following is the first symptom in acne rosacea, guys? Flushing is the. And which of the following is the most common? Telangiectasia. Then the complication of this of persistent erythema and complication of acne rosacea is rhinopyma, guys. Rhinopyma. This is a complication. You have to remember. Then ocular can also be involved, and these are the things that can exacerbate the symptoms. They were going to give you which of the whole scenario of acne rosacea. A patient has presented to you with flushing and papules on his face, and he has been diagnosed with acne rosacea, or they will not going to give you this. And they will go, which of the following has exacerbated the symptoms? Drinking alcohol, sunlight, pregnancy. Treatment. Mild symptoms, only topical metronidazole. These are the mild symptoms. Predominantly flushing, a tropical brominidine, guys. Then, if it is severe disease, you have to start the patient on oral tetracycline. This is how you're going to get the question. They're going to give you the classification. The patient has less papules but no plaques. The patient has predominant flushing. The patient has a severe disease with ocular involvement. So, guys, this is how they're going to give you the question. You can use the sunblocks, you can use laser therapy, and rhinopyma, refer to dermatology. A patient is known case of acne rosacea. He has developed rhinopyma. What will be your management? Refer to dermatology. This is how you're going to get a question. Okay, next question. Next question is eczema herpeticum. Eczema herpeticum, guys. Guys, it is a very, very important topic. It is very, you will gonna definitely come across a lot of questions from eczema herpeticum. So first of all, the question they will be asked, what is the causative agent? So guys, herpes simplex virus 1 or 2 is the causative agent. Then in children, it is more. Any guy, how you will gonna get, let's read it, then I'm gonna tell how you will gonna get the question. In children who has a history of ectopic eczema, asthma, atopy, okay, rapidly progressive painful rash, guys, blisters, punched out erosions, 1 millimeter diameter with fever, lethargy, or distress. What are the risk factors? Atopic dermatitis. I told you IgG, asthma can also higher total IgG and untreated eczema. It is a life-threatening condition. So you have to urgently admit the patient and give IV cyclovir, guys. IV cyclovir. These are the differential diagnoses. If you remember that these are the differential diagnosis, your life will be very easy. the rash in molluscum, we will going to read them later, but you should know that the rash in molluscum conjectuosum, they are umbilicated rash, whereas warts, they are papular rash. Chickenpox, polymorphic vesicular rash. So guys, how you will gonna get a question? The first question will be this: positive organism. The other question will be a patient, a child presented to you with fever, distress. He looks sick. He has a vesicular punched out lesions on his body. He has a history of asthma. Remember, look for this thing: asthma, eczema. What will be your management option? Admit plus IV cyclovir. Guys, this is how you're gonna get the question, and this is their very, very favorite topic. They were gonna give you question from it. Is that clear?
Yes, sir.
Yes, sir. Yes, sir.
Great. So the next thing is molluscum conjectuosum. So you should know what is the organism causing this molluscum conjectum virus. Then you should know that it is also with ectopic eczema. But guys, remember, the rash will be different. Rash, that's why I was emphasizing on the rash, guys. Central umbilicated rash, guys. Okay, central umbilicated rash. There we have already read this. We have already read this, and I have already told you about that. Here it is punched out erosions, punched out erosions. Remember, this is how you study. This is how you differentiate. If you can see here, umbilicated rash. Then next thing is that in adults, it's because of the sexual contact. Just remember this thing. And the management is only reassurance because it is self-limiting. Guys, remember, anything whose treatment is reassurance, it like maybe there are 80% chances you're gonna come in the exam, because they will gonna ask you what they will always gonna ask you something that is atypical. Okay, so you have to remember that molluscum conjectuosum, it will be self-limiting, and they were gonna ask you in how many months? 18 months, guys. Remember it. This is the treatment, same, not usually recommended. I have already told you observation should be there. And then if very like cosmetic reasons or anything else, you can go for cryotherapy, guys. Okay, if this is with HIV, of course you have to refer the patient to the HIV specialist. If it is with on the eyelid margin or ocular red eye, refer to the ophthalmologist. This is how the question statement will gonna change. They will gonna give you, if it is rash on any other part of the body, no problem. But if the rash is with either HIV positive patient, or if it is mentioned that the rash is on the eyelid margin and the red eye, the treatment will gonna change. You will have to, you will not say observation, you will gonna say refer to the ophthalmologist. Is that clear?
Yes, sir.
Yes.
Great. So the next topic is irritant contact dermatitis and allergic contact dermatitis, guys. Irritant contact dermatitis and allergic contact dermatitis. Alkali and acid, whereas contact, we have read already nickel dermatitis, it is type 4 sensitivity reactions. Okay. The other important thing is that contact dermatitis are usually of two types. Cement is frequent cause of contact dermatitis. Okay. Then dichromates in cement, they can cause allergic. Remember, cement is the one that can cause both allergic as well as the contact. Okay. Contact nature is because of the alkalinity of the cement, whereas the contact dermatitis is because of the presence of dichromates. Remember it. They're going to ask you the contact, what you call it, irritant contact dermatitis in cement is because of alkaline nature, whereas allergic contact dermatitis is because of dichromates. Remember this thing, guys. Okay, very important topic. Dermatitis herpetiforms. Guys, how you will gonna get the question for this one? The question that you will gonna, let's just read it first, then I'm gonna tell you, it will make more sense to you. Guys, it is an autoimmune blistering lesion. Remember these things. Associated with celiac disease, it is caused by deposition of IgA in the dermis. The rash will be itchy, vesicular, and on the extensor surface. Then skin biopsy. Skin biopsy. Immunofluorescence will show deposition of IgA in a granular pattern. Management is gluten-free diet and then Depson. So how the questions will gonna come from this? First of all, they will gonna tell you that there is a patient has presented to you with intensely itchy blisters or vesicular rash on the elbow. Then they will gonna give you the scenario of celiac disease. Patient is having anemia, HP will be low. Patient is having difficulty to thrive. Patient is vitamin deficient and he is having rickets, or if it is older patient, osteomalacia, because vitamin D is not being absorbed, calcium is not being absorbed. Anyways, then there will be this scenario as well. Then they're going to ask you, what is the diagnosis? The other thing they will going to ask you is that what will be the investigation you will going to perform? So guys, investigation will be skin biopsy. Skin biopsy. Anything written other than skin biopsy, don't tick it, because they will going to give you so much confusing options. Skin scrapping, something like that. Skin, maybe something else. Please don't select any of it. Only select skin biopsy. Skin biopsy. And they will gonna ask other thing. On skin biopsy, what you will gonna see? Deposition of IgA. Deposition of IgA. Then the next question that you will gonna get is that all the scenario of dermatitis herpetiform and celiac disease, what will be your first line of management? Please don't give Depson as first line. First, ask the patient to have gluten-free diet. This is the first line of management. Then you will gonna shift to Depson. Is that clear?
Yes, sir.
Yes, sir.
Okay.
Yes, sir. Yes, sir.
Next is, thank you. Next is hyperhidrosis, guys. Excessive sweating. Excessive sweating. Excessive sweating can be of any reason. Hyperthyroidism can excessive sweating. Anxiety can cause excessive sweating. Okay, but there are certain reasons in which there is no cause, but still patient can have this. So guys, what are the options of treatment? They will gonna ask you those. Topical ammonium chloride. This is their favorite question. Topical ammonium chloride, first line. Then botulinum toxin can also be used for axillary symptoms. Then surgery, endoscopic transthoracic symplectomy, that can also be used. The question they were going to ask you is this and this. Then we have the next topic of seborrheic dermatitis. Seborrheic dermatitis, guys. Remember, it is because of the proliferation of the normal skin inhabitants. This is the fungus that is being proliferated. Okay, and how you are gonna get the question is that a patient has presented to you with a white scaly rash, periorbital region, or nasolabial rash, scaly rash. Remember, associated dandruff, and it is of seborrheic dermatitis. Remember, any patient who is having scaly rash on the nasolabial fold or eyelids, periorbital region, it is seborrheic dermatitis, guys. Then it can cause otitis externa, blepharitis. Okay. The other important thing they were going to ask you is this, guy. Associated condition, HIV. HIV. Then Parkinsonism. autoimmune thyroid disease. These are the associated conditions of seborrheic dermatitis. They can ask you this one. Remember it. How you will gonna manage? First of all, you will gonna give the patient with zinc containing shampoos, okay, and tar. First line. Then second line will be ketoconazole. So remember this first line, second line. They were gonna give you that he has been given this tar shampoo and now not getting better. So now you have to move on to ketoconazole. Okay, this is how you're gonna be asked. Still not getting better, selenium sulfide and topical steroid can also be used. Guys, topical antifungal, topical steroid, and reassurance is important. Okay. Next is erythroderma. Erythroderma is a journal term. Okay, it is a journal term just for your information. Like it's not like any condition. It's a journal term in which more than 95% of the skin is red and have a rash. It is called erythroderma. It can be in eczema, it can be in psoriasis, it can be in lymphomas, in it like that. So it's a journal term just for your information. Erythrodermic psoriasis. Erythrodermic psoriasis is when you will gonna cut down the steroids, there will be rebound redness, okay, which is because of you are stopping the steroids. That's a side effect of it, okay. And it can, because more than 95% of the skin is red, so you have to admit the patient for that. It's just for your information, guys. Okay, this one is important, guys. I told you that teardrop papules will be there. This will be very typical. A patient, a child who has sore throat, they will not going to give you this streptococcal infection. They are going to give you this sore throat or skin infection, something like that. Okay, mostly it will be sore throat. And after that, the patient has developed multiple papular rash or plague-like rash on the skin, which appear as a dewdrop. What is your diagnosis? Tooth psoriasis, guys. This is how you will going to get the question from it. Resolve spontaneously within 2 to 3 months. Remember it. Remember it, guys. Remember it. If not, treatment is same as that of the other psoriasis. Okay, so now they are asking you to differentiate between psoriasis, which is grade psoriasis, and pityriasis rosacea. So first of all, let's read pityriasis rosacea. You should know what it is. Then you will automatically gonna look for the difference in them. So guys, the question you're gonna get is from this topic is that how or what is the causative organism? They love to ask the causative organisms because they are difficult to remember for every condition. So that's where they will gonna assess you. Then what will happen next? The next thing that they will gonna ask you is this. They're gonna tell you there is a herald apparent patch, usually on the trunk, guys, followed by erythematous oval scaly patch, and the scales will be mostly inside the edge. Follow a characteristic distribution with a longitudinal diameter of oval lesion running parallel to the line of Langer. Guys, this is a very, very important presentation because this is how you will gonna get the question. You have to remember this presentation of the rash because then only you will be able to differentiate. They will gonna tell you that there is a herald rash or there is fir tree appearance. Okay, fir tree is like that, guys. Okay, it's a tree, fir tree basically. So when you will gonna see the picture of pityriasis rosacea and read this what you call it, this appearance, it will be making more sense to you. Okay, don't read blindly, because if you're gonna read it blindly, you will not gonna be able to retain it. Once you will gonna see it, then read it, it will gonna make more sense to you. Okay, then remember, guys, this is very typical. They will gonna give you in the question the scaly patches which are inside of the edge of the rash. Okay, fir tree appearance. Side mostly on the trunk, thighs, chest, upper arms, back, but usually spares the face. Then, which of the following drugs are the reason for pityriasis rosacea? These are the drugs that can cause pityriasis rosacea. You have to remember those, guys. Management, self-limiting. Remember the time, guys. Remember the time. 6 to 12 weeks. They will definitely gonna ask you. They will gonna ask, write it like that. Self-limiting in 6 weeks. Self-limiting in 18 weeks. Self-limiting in 6 months, like that. So, guys, you have to remember it's 6 weeks. Whereas molluscum conjunctivism, it was 18 weeks. Okay, so now we're going to read the difference. Now it's going to make more sense for you guys. I told you, sore throat, gouted psoriasis. Whereas pityriasis rosacea, they will not going to give you this thing. They will not going to confuse you with. They have already written, not common in question. So don't worry. Important difference will be from here. It will be teardrop, okay, whereas it will be Harrell patch, oval lesion, scale confined to the outer aspect of the lesion. Very important, guys. Okay? Fifth reappearance. Then resolves spontaneously in 2 to 3 months. Self-limiting in 6 to 12 weeks. Remember it. Remember it, guys. This is how you're going to be differentiating. Then psoriasis and this one. So now I think the difference would be clear to you guys. Okay. So guys, next topic is Pityris versicolor. This is Pityris rosacea. Remember it. It will gonna create a lot of confusion to you. So better to read this with the help of diagrams so that you don't forget it. Okay. That was Pityris rosacea. This is Pityris versicolor. Okay, pityriasis versicolor is basically a fungal infection. It is a fungal infection. Okay, and Malassezia furfur is the organism. Very important and favorite question: which organism is causing this? Then they were gonna tell you hypopigmented pink or brown rash, guys. This is typical hypopigmented rash. Hypopigmented, hypopigmented pink rash with itching. With itching. Management, ketoconazole shampoo. Ketoconazole shampoo, guys. These are the this is the management option. If not treated, you can give the oral antifungal as well. Okay. Next topic is pyoderma gangrenosum. Pyoderma gangrenosum, whenever you will gonna get a question in which they will gonna tell you that a patient has a red deep necrotic ulcer with bilious borders on the lower limb, please select pyoderma gangrenosum. The words that are written here, they will gonna be there in the statement. This one will definitely be gonna there: red necrotic and bilious border, or they were gonna say red with bilious border or red with necrotic. Guys, remember, the red necrotic bad looking ulcer on the lower limb is pyoderma gangrenosum, which can be associated with all of these conditions. They were gonna tell you a patient has Crohn. They will not gonna tell you Crohn disease. They will gonna give you the symptom. The patient has multiple episodes of loose stools. The patient has along with that, the patient has rash with red bilious border on the lower limb. What is the diagnosis? SLE, lymphoma, clonal monoclonal gammopathy, diabetes. So guys, what is the treatment? It is a very aggressive thing. So the treatment will be oral steroids, guys. As the rash is angry looking rash, so we will gonna treat it aggressively. And that is why oral steroid. This is a very confusing MCQs. They were gonna give you topical steroid, and most of the candidates were gonna select topical steroids because they were gonna think it is derma, and we are gonna first give topical steroids. No, you're gonna give oral steroids in pyoderma gangrenosum. Guys, this is what I was telling you. Very angry looking rash. angry with necrosis, black necrosis, and glacious borders. This is how pyoderma gangrenosum presents. Then the next topic is erythema nodosum, guys. How you will gonna get the question? The question first, read it, then we're gonna talk about it. It will gonna make more sense. Inflammation of the subcutaneous fat, which will gonna cause tenderness, erythematous nodular lesions. Guys, always focus on the nature of the lesion because this will gonna help you differentiate in the exam. Nodular lesion and tender. Then mostly over the shin, can also present on forearm and thighs. So don't forget. Okay. Then resolve on their own without scarring within 6 weeks. What can be the cause? Most common cause, streptococcus infection. Streptococcus infection, guys. TB, brucellosis, sarcoidosis, inflammatory bowel disease, Behçet's, malignancy, drugs, penicillin, sulfonamides. These are the drugs, COPCs. Guys, remember these drugs, they will gonna ask you which of the following drug is associated with erythema nodosum. So you have to remember it. You have to remember it, guys. So how you will gonna get the question, guys? The question you will gonna get is that a patient, she is 8 weeks pregnant, has presented to you with a nodular erythematous rash on his shin. Which of the following is a diagnosis? Erythema nodosum. A patient who has a history of sarcoidosis has presented to you with rash on the shin, which is reddish and nodular. What is the diagnosis? Erythema nodosum. A patient who has sore throat and was started on amoxicillin. After that, he developed a rash on the shin. Erythema nodosum. Penicillin has been started. Guys, this is how you're gonna be asked question about it. Is that clear?
Yes, sir.
Okay. So the next topic is erythema multiforme. We have already read about erythema multiforme multiple times. I have told you that erythema multiforme is associated with the pneumonia, mycoplasma pneumonia, streptococcus pneumonia. With the in the respiratory, we have read that. At the same time, autoimmune hemolytic anemia, we have read that. Okay, so guys, the drugs which cause this this problem, they have written it here. You have to remember it, and you should know what drugs are the reason for erythema multiforme, guys. So what is erythema multiforme? First of all, erythema multiforme, whenever you will gonna read in the scenario that the patient has target lesions, guys. What are target lesion? It will gonna appear like this. Target, like if someone know that what is archery, there is a target. Okay, so these lesions, they appear as a target lesions. So this is why there will be a history of patient having shortness of breath, patient having cough, and he has a rash on his body which looks like a target. Guys, always select erythema multiforme, or they're gonna tell you that the rash is there is round rash, mucosal rash with central redness. Guys, this is target like explanation. Okay, so guys, always remember this, and the important thing is herpes simplex, most common cause. Herpes simplex, most common cause. Which of the following is the most common cause of erythema multiforme? Herpes simplex virus, guys. Then, which of the following is not a cause of erythema multiforme? So guys, they will gonna give all of these. One will be not there. One will not be the cause. So you have to select that. Similarly, which of the following drug is not a cause of this one, erythema multiforme? So guys, the drugs option will be there, and all the drugs that are causing is here. The list is here. So you have to remember it, because anything can come in the exam like that. Erythema, not usually common in the exam, but can come. We don't know. Generally asymptomatic. Okay, flat, slightly scaly, pink rash, mostly in the groin region. Okay, mostly in the groin region, and it is because of the overgrowth of the coronary bacterium. Coronary bacterium. Red coral red fluorescence will be there if you are gonna see the skin scraping under the microscope. Then meconazole can be used, and if it is more extensive, erythromycin can be used. Just have a look at it, guys. Just have a look at it, and remember this coral red fluorescence, because such atypical diseases which are not that common, they will definitely gonna give you some important clue. Very important clue they will gonna give you, because these diseases, they are very confusing, so they will not gonna give you that only they have this, and they will not gonna, they're definitely gonna give you this coral red fluorescence. Okay, next topic is important. Impetigo, guys. Remember, impetigo is caused by staph aureus or streptococcus pyogenes. The other important thing they will gonna ask you is that it is common in children, and it is very, very, very contagious. Direct contact with the discharge, it will gonna cause it. It will gonna cause the it will gonna spread. It will gonna definitely gonna spread, guys. So features: golden honey-like crusted lesions. Wherever you see this term, golden honey-like crusted lesion around the face, around the lips. Close your eyes and select impetigo, guys. Then management. First of all, the first line of treatment is fusidic acid. Fusidic acid. Okay. Then you should consider hospital stay and following surgery if there is MRSA involvement. You have done a culture and there is MRSA, so please don't send the patient. Just ask him to stay, because MRSA can spread. It is a very resistant bacteria, so that's why. So if there is this situation, topical mupirocin is used for MRSA, guys. Most important, they will gonna tell you that the honey crusted lesion, which of the following is your first line of management? First line of management is topical fusidic acid, guys. If they will gonna tell you that hydrogen peroxide, if it is present along with fusidic acid, please select hydrogen peroxide, because that is the first thing that you will gonna use in patient with this what you call it, impetigo. Okay, so but mostly they will gonna give you this fusidic acid, but remember hydrogen peroxide. Okay, it is not written here, but I'm telling. Anyways, the next important thing is that you should remember that if the disease is extensive, you will gonna give oral fluoxetine, but if the patient is penicillin allergic, erythromycin should be used. And the question will gonna come that the child has this problem, when he can return to school. Until the lesions are crusted and healed, or 48 hours after commencing antibiotic therapy. This is how you can get a question. But remember, honey crusted lesions on face, around the lips, very contagious. Fusidic acid first line, MRSA is muprocin, and if when you will gonna send the child back to school after 48 hours. Okay. Next topic is bullous pemphigoid, guys. Bullous pemphigoid. The bullous pemphigoid and pemphigus vulgaris, they are one of the most important topic from this dermatology, because they are confusing. There are some differences between them. You have to remember, and you should know how things go in this. So focus on those things, guys. How you will gonna get a question? The first question you will gonna get is that bullous pemphigoid is associated with antibodies against hemidesmosomal protein BP180 and BP230, guys. Remember it. This is what they will gonna ask you first. Second, Remember it that the lesion of the bullous pemphigoid, they are itchy. Very typical of this. They are itchy, guys. Then, as the name suggests, bullous, so it means it is bulla, which is tense. Tense. Tense mean that they are filled with fluid, so they are tense. Tense blisters. Okay? Then they usually heal without scarring. Mouth is usually spared. No lesions of bullous pemphigoid in mouth. Guys, remember. So, what we have learned. First, the antibodies. Second, if the lesion is itchy, tense, and is not present in the mouth. Very typical presentation that will gonna come in the exam, guys. And remember that on skin biopsy, you will gonna get IgG and C3 at the dermoepidermal junctions. Refer to the dermatologist for biopsy, and you will gonna start the patient on oral steroids. Okay, now, guys, the next topic is pemphigus vulgaris. We have already read that about the bullous. Now we're gonna read about the pemphigus. So in pemphigus, the antibodies are against desmoglein, guys. Remember, this is the first difference. Second difference is the oral involvement. There, oral involvement was not there. Here, mucosal oral involvement is there. Second, there were blisters, tense. Here, it is flaccid. Okay, there they were tense. Here, it is flaccid. Then, guys, these lesions, they are not itchy. They were itchy. Remember, then. So these are the major differences on which you will be able to differentiate both of these diseases in the question. Is it clear?
Yes, sir.
Yes, sir.
Yes. So that will gonna make your life easy. Remembering that which is itchy, which is not, which is tense, which is not, which is having mucosal involvement, which is not, that will gonna make your life absolutely easy, guys. Remember it. Similarly, steroids is the first line of therapy, guys. Here, again, written the differences, guys. No mucosal involvement, mucosal involvement. Desmosomal antibodies, and here it is against desmoglein. Keratocanthoma, 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 guys. Guys, when you are reading dermatology, please see the pictures from Google, please, because it will gonna help you a lot in remembering things. If you will not gonna read, you will not gonna know what is smooth dome shaped papule, what is catheter filled with keratin. You will not gonna know what it is, and you will gonna forget it. So please, whenever you are reading dermatology, keep your Google open and search it. What is keratocanthoma? Open the picture. When you will gonna see the picture, read it. Then it will gonna make very common sense to you. The important question that you will gonna get from this is this one, guys. Difficult clinically to exclude from squamous cell carcinoma, so it should be urgently excised. Urgently excised. Urgently excised. This is what it is important, guys. And when you will gonna see the picture, attached picture, I have already explained to you the volcano-like appearance with the central keratin formation. This is the keratin formation. This is what it is called as keratocanthoma, guys. Then keloid scars. What you will gonna get? You will gonna get the patient had a surgery. He has an incisional scar now, and it has become big, and it has developed keloid. What is your treatment option? So, guys, the treatment options will be intralesional steroid. You have to give steroid in the lesion. So, what exactly is there? There will be a scar, okay, and there will be usually in dark skinned people, and these are the common sites where the scar cannot be commonly present: sternum, shoulder, neck, face, external surface of the limb, and neck. They will gonna ask you which of the following is the most common site of development of keloid. Sternum. Then, how you can prevent the development of keloid, guys? This is the other question. The thing is that Lange lines used to determine the optimal lesion line have been shown to produce worse cosmetic results than when following skin tension lines. So if you are going to give the incision along the skin tension line, keloids will not be formed. But if you're going to do this, keloids can be formed. Okay, what is Kovner's phenomena, guys? Kovner's phenomena is a phenomena whenever there is a little mild injury to the skin, there will be a lesion. There will be a lesion, redness, lesion. What will gonna be the cause for that, guys? Psoriasis. Or in all of these conditions, Kovner phenomena will be seen. They will going to ask you which of the following is not associated with Kovner's phenomena. So you will going to be given everything. One thing will also be there. Maybe it will be, for example, psoriasis is there, vitiligo is there, warts are there, lichen planet from Figus vulgaris. So it is the answer. This is how you will going to be asking. You will be asked about the questions, guys. Then you have actinic keratosis, guys. Actinic keratosis. Actinic keratosis. Pre-malignant skin disease. Very dangerous. Very dangerous due to chronic sun exposure. Okay. Small, flat, erythematous lesion, maybe crusty or scaly, pink, red, brown, or same color of the skin. Mostly in the sun exposed areas. Multiple lesions. So guys, how you are going to get the question from this? The question will be a farmer or um, a, a gardener has developed small brownish scaly lesions on his hands. Guys, multiple scaly lesion in a sun exposed area with flat brownish color. It is actinic keratosis, guys. Management, avoid sun. This one, fluorouracil cream can be used. Okay. After using this, skin can become red and inflamed. So to decrease the redness and inflammation, you can combine fluorouracil with steroids, guys. Okay. And it should be given following fluorouracil, not together with fluorouracil, guys. Remember. Then topical diclofenac can also be used. Topical midoquine can also be used. But this is important. Fluorouracil cream is used in this condition, guys. Okay. Next important topic is melanoma. Melanoma, guys. How you will gonna get a question from melanoma? Okay. First of all, they will gonna tell you that the melanoma is in situ. Okay. Flat brown pigmentation with irregular edges. Okay. What is the condition? It will be lentigo maligna, guys. Lentigo maligna. If they were gonna say in situ, it will be lentigo maligna. They want to know that what exactly you know about the name. So if they tell you that the lesion is in situ, just select lentigo maligna. Then, if it is malignant melanoma, which is not in situ, there can be superficial, nodular, and acral as well. Lentigo we have already read. So most common one is superficial spreading one, whereas the most aggressive one is the nodular one, guys. This is what you're gonna get a question. Which of the following type of melanoma is most common? Superficial spreading. Which of the following is the most aggressive? Nodular one. Then acral basically means the nails. Okay, acral is actually the nails. So any melanoma which develop in nails, palm, sole, it is acral melanoma, guys. Okay. The other important thing that you will gonna get in melanoma is this one, guys. Diagnostic major criteria and minor criteria for melanoma. If there is a change in size, change in shape, change in color, very, very major criteria for melanoma, guys. Very major type of melanoma. And the other less common or secondary minor criteria, diameter more than 6 mm, inflammation, oozing or bleeding, decreased sensation. This is the minor, but the major is change in size, color, and shape. Then the important thing that you will gonna get is this. The important thing that you will gonna get is this from melanoma, prognostic factor. The prognostic factor is the invasion depth of the tumor. Depth of the tumor is the prognosis factor. Which of the following is the prognostic factor of melanoma? Depth of the tumor, size of the tumor, shape of the tumor. So guys, the answer will be depth of the tumor. Remember, it's a very favorite question. Depth of the tumor, invasion depth of the tumor is a prognostic factor, guys. Then the other thing they were going to give you is that depth of the tumor is 1 to 2 mm. What is the 5-year survival rate? This one. Depth of the tumor is more than 4 mm. What is the median survival rate of 5 years? So you have to memorize this table, guys. Okay. So if it is a it is a lesion that you are suspecting melanoma, you have to do excision biopsy. Excision biopsy and histopathology. Once it is confirmed that it is melanoma, then you have to determine the where is the spread, up till what is the spread. So you have to further examine and re-excise the margin as required. As required. Now, how you will gonna determine that how much excision you will gonna be doing? So guys, if lesion is 0 to 1 mm in depth, you're gonna do the margin 1 centimeter excision. Lesion 1 to 2 mm, 1 to 2 centimeter is the excision. Lesion 2 to 4, 2 to 3 centimeter. More than 4 mm, 3 centimeter. So guys, these tables, they are a bit difficult, but they are theoretical things that you have to remember. And when you will gonna memorize, it will gonna be easy because they will gonna ask you on histopathology, the depth of the lesion is 2 to 4 mm. What will be the excision size? So guys, 2 to 3 centimeters. This is how you're gonna get the question. Okay. Next topic is erythema ab acne. What is it, guys? Erythema ab acne is basically a rash. It is a rash which is a reddish rash and the hyperpigmented rash with telangiectasias. If you get the question that a lady who is a hypothyroid has presented to you with a rash on the legs or on the back or on any part of the body, okay, the rash is reticulated with hyperpigmented telangiectasias. It is erythema ab acne, guys. How it is formed? It is because of the overexposure to the infrared radiation. A patient who is hypothyroid, she has cold intolerance, so she will continuously be sitting in front of the heater. So guys, remember it. Remember it. This will be very typical presentation. A lady, old age lady presenting to you in front of the open fire or heater, okay, exposure to the heat, then he or she can develop erythema ab acne. They will gonna ask you, if it is not treated, what is the risk? Squamous cell skin cancer is the risk. Is a risk. It can change to squamous cell linked skin cancer, guys. Okay. Next topic is squamous cell carcinoma of the skin. Squamous cell carcinoma of the skin, you have to remember few things. First of all, you have to remember that it is most common malignancy appearing near the lip over the lower lip. Okay. Then the other important thing that you're gonna get is this one, guys. Squamous cell carcinoma arising in chronic scars. Guys, I told you when we were reading nephrology, and I told you if you wanna gonna get a question that a patient underwent of a renal transplant, and later on, which of the following is he predisposed to So the answer will be squamous cell carcinoma, guys, because in chronic scars, squamous cell carcinoma arises. Okay, squamous cell carcinoma arises, guys. Remember it. It is very common. And mostly it will gonna come with this renal transplantation. Remember it, guys. So mostly on the exposed sun surfaces, it will gonna appear. Okay, and smoking is a risk factor. Long-standing leg ulcer can be a risk factor. Genetic condition can be a risk factor. Okay. And the treatment, if it is less than 20 mm, you will gonna excise it with 4 mm of margins. If the tumor is more than 20 mm, then the margin will gonna be 6 mm. Guys, you have to memorize these things. These are all theoretical things. There is nothing concept in them. These are all the things that you have to memorize. So you will gonna get a question that the patient has been diagnosed with squamous cell carcinoma and diameter is 30 mm. What will be the axial margins? 6 mm, guys. Remember it. Then Mohs micrographic surgery after confirming a diagnosis is the treatment. Similarly, the poor prognosis as it was written in melanoma, you have to memorize it. What are the good prognosis? What are the bad prognostic factors? Well demarcated, poorly demarcated. Less than 20, more than 20. Less than 2, 4 mm. Not associated disease, immunosuppression. So guys, this is how you will gonna be assessed on this. Next topic is basal cell carcinoma, guys. Basal cell carcinoma will gonna is a rodent ulcer actually. Okay, so this ulcer usually present, guys, that the presentation of this ulcer is that they sorry the presentation of this ulcer is that they are also in sun exposed area, mostly in the head and neck region. Okay, but the important part is that the ulcer will be this lesion will be ulcerated, okay, with telangiectasias, guys, with telangiectasia, and it has a rolled margins. It has a rolled margins. If there is any picture, no. So when you will gonna open the picture in the Google, you're gonna see that there will be rolled margins like this. The margins will be rolled, and in the center there will be telangiectasias and necrotic tissues. Then ulceration, central depression, okay, and there will be waxy patches or firm, rough, waxy patches often on the cheek. That's not important. The only important thing is rolled edges with central telangiectasias and central depression. Routine referral, if a patient is having suspicion of this, excision biopsy is not necessary if as it is a clinical diagnosis. Management, same. Most surgical removal is the option. You can do curettage, cryotherapy, topical cream, and radiotherapy as well. Okay, so the next thing is, so the question that you will gonna get from this basal cell carcinoma, guys, I have already told you that they will gonna tell you that it is a gardener or it is a farmer or like this, and they have presented to you with a rash on the temple region or cheek region, and they will gonna describe the rash or the lesion, rolled edges, pearly white with central telangiectasia. So guys, it is basal cell carcinoma. Systemic masticosis, what exactly is it is a proliferation of the mast cell, guys. Mast cell, the cell which are usually associated with the inflammatory reactions, mast cells. So because it is mast cells, so there will be wheal on rubbing, flushing, abdominal pain, and on the blood film there will be monocytosis. Serum tryptase levels will be high because it is an allergic reaction. Okay, this is not that important. Just remember it. What you will gonna get: serum tryptase is high, urinary histamine levels are there, and the patient will be having flushing, abdominal pain. Okay. Next topic is venous ulceration. Venous ulceration. Guys, the only thing you have to remember about venous ulceration is this. Guys, if the lesion, is above the medial malleolus, And guys, and they have told you that the arterial brachial index is normal. You have to select venous ulcer. Ankle brachial pressure index is actually what it shows. It is the index which shows the non-healing ulcer to assess for poor arterial flow, guys. Okay, if it is abnormal, then you have to refer the patient to the vascular surgeon because the blood supply is reduced. So if you have to memorize this thing, guys. If it is less than 2, the ankle brachial index, it means it's arterial disease. If it is more than 3, 1.3, indicate arterial disease. It also indicates the arterial disease. Okay, but remember the normal is from 0.9 to 1.3. 0.9 to 1.3. They're going to check the pressure from the ankle and brachial, and then they're going to find an index, and it will going to show the poor arterial flow if it is less than 0.9 or more than 1.3. What is the treatment? Treatment is, guys, compression banding. Compression banding. Compression banding, very important. Okay, then if the ulcer fails to heal, refer for consideration biopsy to exclude the malignancy. Oral pentoxaphylline cause vasodilation and it can cause healing of the ulcer. Little evidence of hydrocolloid dressing, so no need for that. You have to remember only one thing, and that is compression banding. This is what you will going to get in exam. A patient who has presented to you with ulcer on the medial aspect of the malleolus, okay, and the ankle brachial index is normal, it means it is a venous ulcer. And what you will gonna do? Compression banding. Is that clear?
Yes, sir. Yes, doctor.
Great. So the next thing is vitiligo. In vitiligo, what you will gonna get is that you will gonna get that which of the following is associated with vitiligo? Autoimmune diseases, all the autoimmune diseases, guys. All the autoimmune diseases are associated with vitiligo. How you will gonna get the question? The question will be: a patient is a known case of type 1 diabetes mellitus or Addison's disease or pernicious anemia, has presented to you with depigmented lesions, guys. Remember, the question that you will gonna get is a depigmented lesion. Depigmented, guys. If it is written hypopigmented, don't consider it. Depigmented. Depigmented lesions and autoimmune disease, select vitiligo, guys. What is the management? Sunblock or topical steroid, very rarely changes. Okay, and topical tacrolimus can also be used. So please don't forget to remember the other treatments as well, because they can give you that sunblock has been used, steroid has been used, what you will gonna do next. So you have to do topical tacrolimus. Okay, like this. Okay, what can be the reason? Idiopathic polyarthritis nodosa, we read that in rheumatology. SLE, chiroglobinemia, we read it in hematology. Antiphospholipid syndrome, we read it. ED syndrome, homocystinuria. This is what, guys, it looks like. Reticulated rash, a net-like rash, and it is very common in patients after primary cutaneous intervention, PCI. It can also occur. This rash can also occur after that. Then we have pruritus. What are the reasons in which the pruritus is common? Just go through it. You should know what are the reasons for pruritus. Liver disease can be the reason for pruritus. Alcohol excess, chronic liver disease. These are the reason for iron deficiency is the cause. That is why patients with CKD, they have pruritus on their skin. Polycythemia. We know that after a warm bath, we have read that. We have read that. We have read that. Chronic kidney disease, I have already told you, patient have the pruritus. Lymphoma, patient can have pruritus. Other causes are these which can cause pruritus. You should know about them. Pyoderma gangrenosum, it is here written again. We have already read that and I have already explained it to you. Porphyria cutanea tarda, we have read that in hematology. If you remember hematology, we read with porphyria cutanea tarda, guys. Okay, so I'm gonna revise it again so that you should know. Most common hepatic porphyria, this is the enzyme which is deficient. And if you will gonna get a question that the patient has pruritus, patient has hepatitis C, and patient is having blistering rash, guys, it is porphyria cutanea tarda. This is the presentation: rash, blistering with skin fragility, along with hep C or B, please, and hypertrichosis, hyperpigmentation. Select, 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 please select porphyria cutanea tarda. What investigation you will gonna do? Of course, the enzyme that is deficient, you will gonna see that it is more in the urine, pink fluorescence of urine under the wood lamp. And management, very important. They're gonna ask you, because it's a very atypical management. Chloroquine, venesection is the other option, guys. Just remember, any patient having photosensitive rash, blistering rash, skin, along with having alcohol or hepatitis C or estrogen hepatic damage, is this porphyria, and you have to remember the chloroquine. Okay, next important topic is scabies. We all know scabies. We all have encountered patient with scabies, so it's very simple, but it is important. What you have to remember, first of all, the causative organism. Sarcoptes scabi is the answer. Then the other thing you have to remember, which they ask, is this: type 4 hypersensitivity reaction. Then the other thing they will gonna give you is that a child or a family member has the linear burrows in the interdigital webs. Okay, what is the diagnosis? Scabies. Other important thing, parametamine 5% is the first line of treatment. Then the other important thing, they will gonna tell you patient has been treated with parametamine 5%, but patient is still having the itching. What will be your management option? Guys, your answer will be wait for 4 to 6 weeks. Don't select repeat treatment or change to Melathon, something like that, because pruritus will persist up till 4 to 6 weeks of treatment. Remember, it is the most important question that you will gonna get. Okay, and this is the guidance which is for the patient who are having this what you call it, scabies, that avoid the contact, and all the contacts should be treated. Then you have to laundry your all the clothings and beddings. Okay, then insecticide cream should be applied, and closely monitor or apply the creams in the fingers and toes, nails, armpit area. These are just the general instructions for the patient. Okay, so mostly you should know about this, not only for the exam but for the treatment. You are not here only to give the what you call it exam. You should know, your knowledge should be updated of how you're going to prescribe the medication parametamine to the patient. So this is how it goes, guys. And repeat the treatment after 1 week, remember it. Okay, the other question you're going to get is this, guys: a patient who is HIV positive, and he has developed crusted scabies. What is the treatment? Very favorite question. Ivermectin is the treatment. Parametamine or Melathon are not the options, guys. Here, patients with HIV with crusted scabies, ivermectin is the treatment of choice. Is that clear?
Yes, sir.
Okay. Next is this topic, which is important. This table is very important. They have told you that which of the following skin disorders are present with which of the following cancers. In gastric cancer, I have already told you acanthosis nigra. Lymphoma, acquired ichthyosis. GI or lung cancer, acquired hypertrichosis rhyngitis. Then ovarian or lung cancer, dermatomyositis. Okay. Then erythema granitum ripum, also known as wood grain pattern, and it will be associated with lung cancer, erythroderma, lymphoma, migratory thrombophlebitis, pancreatic cancer. Guys, the important one which will gonna come in the exam, this one, this one, this one. Remember it. All are important, but these are commonly repeated one. These are commonly repeated one. They will gonna tell you that a patient has a skin lesion which is erythema granitum repens, like a wood grain pattern. Which of the following is the underlying cancer? Lung cancer. Or a patient has gastric cancer. Which of the following lesion of skin is associated with it? Acanthosis nigrans. A patient has migratory thrombophlebitis. Which of the following? Or a patient is having a pancreatic cancer. Which skin lesion will be there? Migratory thrombophlebitis, guys. Similarly, a patient has been diagnosed with glaucoma. Which of the following? These two are very confusing. So they will gonna give you these two definitely there, and that's why it is highlighted, guys. Remember, because it is necrolytic migratory erythema and it is migratory thrombophlebitis. So people, candidates, they mix it. So that is why it is important. Then, sweet syndrome, malignancy, hematological malignancy, and Tyrolysis, esophageal cancer. Remember this table, guys. You have to memorize it by heart. You can get any of it. Any of it, guys. Okay. Now we're gonna read about the what you call it, skin lesions in the pregnancy, and I'm gonna tell you that how they are here and how they appear, guys. So first one is the melasma, guys. Melasma, we all know that they are brown pigmented patch around the cheeks, forehead, and nose, and they resolve after a few months of pregnancy, mostly, but not in all patients. They it's not necessary that they will gonna resolve in all patients. Then, guys, the next is atopic eruption of pregnancy. I'm gonna tell you that how the question and from where the question is gonna come. Don't worry. So atopic eruption is skin. It is eczematis redolent. No specific treatment needed. Guys, these two are the important one from which the exam the question is gonna come. Polymorphic eruption of pregnancy, guys. First of all, remember, it will gonna appear in last trimester. This is the first difference. And it will gonna appear in the abdominal strias, guys. These abdominal stria, you can see here, abdominal strias. What is the management? Emollient, mild potency steroids, guys. Then the other is pemphigoid gestanosis, guys. As the name suggests, that pemphigoid that is being present in the gestational age. So, guys, these will also be periodic, but remember, these will be peri-umbilical region. These were in the abdominal strias. These are in the peri-umbilical region. Then it will be in the second or third pregnancy, very rarely in the first pregnancy, first trimester. Very rarely in the first pregnancy. Remember, it is a differentiating point, guys. They're gonna tell you that a lady is gravida para 2, maybe having second pregnancy, maybe having third pregnancy, not the first pregnancy. They will always be present in the later pregnancies, second, third. And here, oral steroids, not the topical one. Here, topical were being used, guys. Remember, mild topical steroid, but here, oral steroids. This is how you read and study for this topic, that you should know that polymorphic eruption and pemphigoid gestation are different things and how they will gonna be treated when they will gonna be present. We have already read about these shin lesions, so nothing much to read about that. The only thing that I want to tell you is this one. Peritibial myxedema. It is common in patients with Graves' disease, and the skin will be shiny orange peel skin. If you get a scenario that a patient has presented to you with this leg lesion, the lesion look like orange peel skin, guys. Orange peel skin. Select. It will definitely be there. Orange peel skin. Select peritibial myxedema. Other topic, other question that you will gonna get. Other question that you will gonna get is a patient is diabetic. 100% the patient will be diabetic. 100%. Shiny, painless area of a red skin lesion plus telangiectasias. It will be necrobiosis, lipodika, diabetic. This is very typical question in the exam. A patient who is diabetic has presented to you with a shin ulcer and the ulcer is yellowish along with telangiectasias. Guys, this is the key point. Diabetes and this shin lesion which is having telangiectasias. Is that clear?
Yes, sir. Yes, doctor.
Okay. Next is granuloma annulare. Okay. And granuloma annulare is a lesion slightly hyperpigmented, depressed central. Guys, see the pictures. When you're gonna see the picture and read it, it will be very, very clear in your mind. Hands and feet, extensive surface of the arm, and number association have associated with diabetes mellitus. Okay, so just have a look at it. Just have a look at it. Diabetes, we have already read pyoderma gangrenosum. This we have already read, and the only thing we need to read is this neurotropic ulcer. We know patients with diabetes, they develop pressure ulcers, mostly on the toes and on the foot because of the neuropathy. That is why it is called neuropathic ulcers, guys. Okay, skin associated with tuberculosis, lupus vulgaris, which is most common. Okay, and what exactly is this? Face is the common around the nose and mouth. Erythematous flat lesions, erythema nodosum can be there, and this is important. This is sacrofluderma, breakdown of the skin over the tuberous focus, guys. This is the feature of this one, lupus vulgaris. They were going to ask you which of the following is the feature of lupus vulgaris. This one, guys. Sacrofluderma is the feature. Okay, not that come, but you just have to read through it. Go through it, guys. Okay, next topic is Stevens-Johnson syndrome. Stevens-Johnson syndrome. We all know that, we have read about it a lot of time. So what exactly it is, guys? Exactly it is that it is because of a drug reaction. The other thing is that it's a delayed hypersensitivity T cell reaction. You should know it. You should know it, guys. Know it. Then target lesions with maculopapular rash, okay, may develop into vesicles and bulla. Okay, mucosal involvement is common. Fever, arthralgia will be there. The question you will gonna get is this: a patient has been started on anti-lactic medication, or a patient has been started on a medication for gout. He has developed a rash on his body, which is a vesicular rash with mucosal involvement. Patient is also feverish, having arthralgia. Which of the following is the diagnosis? Stevens-Johnson syndrome, guys. Guys, remember, you will be asked a lot of times which of the following drugs are the reason for Stevens-Johnson syndrome. Which of the following drug is not a cause of Stevens-Johnson? This is very important. Stevens-Johnson's very important. What are the causes? What things can cause Stevens-Johnson? These drugs. They want you to know the name by heart. I'm telling you. And they will gonna give you that the patient has presented to you with the target lesion, rash, with vesicles, and with mucosal involvement, and now the patient is having fever and arthralgia and systemic symptoms. Okay, patient is sick. Which of the following is the cause? Penicillin. They're gonna give you multiple things. They're gonna give you multiple things in it. That the patient is diabetic. Patient is they were gonna make you confused. They're gonna make you confused. The patient is diabetic. Patient is this. Patient is that. But the only catching point will be that any one of these drugs will be started. Will have been started. Either oral contraceptive pills. Mostly they're gonna give you this one, oral contraceptive pills, and these anti-epileptics. Hospital admission is required and supportive management. Okay. Next topic is toxic epidermal necrosis. It is similarly same as that of Stevens-Johnson syndrome. But the thing is that here, the area that is involved is extensive. Okay, the area that is involved in extent, that's why we call this toxic epidermal necrosis, guys. Life-threatening condition. It is also because of the drug reactions. Okay, and might be severe and spectral skin erythema multiforme and Steven-Johnson syndrome, guys, because the area is extensive. The area is extensive, guys. Okay, same condition like that of Steven-Johnson's. Phenytoin drugs will also be almost the same, but if the area is more, then you have to call it toxic epidermal necrosis, guys. ICU care, IV immunoglobulins are the first line of management. Okay. Plagra. Plagra is also a skin condition, guys. Plagra is also a skin condition consisting of dermatitis, diarrhea, dementia, and death. How you will gonna get the question? The question you will gonna get is that a patient is diagnosed with TB. He has been started on medication, and after maybe 3 months, 4 months, 5 months, whatever the time is, patient has developed a brown scaly rash on the neck, okay, and the patient has frequent diarrhea, or the patient feel depressed, guys. This neck rash, brown black neck rash, scaly rash, along with the starting of TB medication isoniazid, guys, it is plagra. Isoniazid decrease the conversion of tryptophan to niacin, and because of that there is niacin deficiency, and because of this niacin deficiency the patient will gonna get dermatitis, diarrhea, dementia. Is that clear?
Yes, sir.
Yes. So please look for these two things, alcoholic and isoniazid therapy. They will not gonna tell you isoniazid, they will gonna tell you patient is being treated for TB. Okay, so that's how you have to remember, but they will gonna definitely gonna give you a rash on the neck. This is very typical of this dermatitis. Next we have zinc deficiency. They will gonna ask you, they will gonna tell you that in zinc deficiency the patient is having alopecia, the patient is having crusted lesions, red crusted lesions around the lips or tongue. Remember, crusted lesions fissuring around the tongue or thing, it is zinc deficiency, guys. This is the question that you will gonna get. Okay. Next is fungal infection, guys. Fungal infections. Fungal infection is onychomycosis if the infection is caused by in the nails, caused by dermatophytes, and this one is the commonest cause. Trichophyton rubrum is the commonest cause, guys. Okay, so the important thing to remember in this is this one, guys. Management. You have to remember the management. If a patient is asymptomatic and the patient is not bothered by the appearance of the nails, okay, no need to treat. Diagnosis should be confirmed by microscopy before starting the treatment. Okay, so what is the treatment, guys? Remember, if it is a dermophyte infection, oral terbinafine should be used. Guys, these are the critical things. You have to remember these things, guys. Then, oral terbinafine should be used first line with oral itraconazole as an alternative. If this is not recommended or allergy or something, oral itraconazole can be used. Then, if it is a fungal nail infection, you have to give the treatment up to 6 weeks to 3 months. If it is a toenail, treatment should be from 3 to 6 months, guys. Then, if it is a candida infection, guys, you can use topical antifungal. But if it is severe, oral itraconazole for 12 weeks. Then, topical treatment can be given for 6 months and for toenails for 6 to 12 months. 9 to 12 months, sorry. Okay. Then, tinea. Tinea, which part of the body is effective? It will be called tinea capitis if scalp, tinea corporis if trunk, leg or arms, tinea pedis if feet. Okay. So, guys, difference between tinea capitis tinea corporis and tinea pedis. This is the table you have to remember. It can cause scarring alopecia. Then this is the commonest organism in it. Then the other important thing that you're gonna get is the management, guys. Management. Remember, they're gonna give you trichophyton is the organism. What is the treatment? Terbinafine. If microsporum is the organism, Drosophilin is the treatment. Guys, this is how you're gonna get. Then they're gonna tell you that patient is having a tinea corporis. What is the treatment? Oral fluconazole is the treatment, guys. Then they're gonna ask you, patient is having athlete foot or pedis. Okay, what treatment options you have for this? Yeah, the treatment options that you're gonna use is oral fluconazole. Fluconazole, guys. Fluconazole. Then, onycholysis. What is onycholysis? Onycholysis is actually the separation of the nail plate from the nail bed. Nail plate from the nail bed. Nail will not be attached to the nail bed. It will be lifted up. This is called onycholysis. These can be the reasons. You have to memorize these lesion because they will gonna ask you which of the following is not a reason for onycholysis, which of the following is a reason for onycholysis. So you have to memorize that. Similarly, yellow nail syndrome, guys. Yellow nail syndrome. It is the yellowness of the nails of the hand, and the nails get thickened and discolored. Yellow nail. It can be associated with lymphedema, pleural effusion, bronchiectasis, chronic sinus infection. You have to memorize these causes. So all the causes, all the different reasons for these are important because you will gonna get questions. Which of the following is not a cause of yellow nail syndrome? Which of the following is a cause of yellow nail syndrome? So that's how you will gonna be assessed from these guys. So, guys, this was all from the dermatology, and I have tried to make it easy for you guys by telling you from where the questions will gonna come, how the questions will gonna come. So now you have the target that how you have to prepare from dermatology. Is that clear, guys?
Yes, sir.
Any question?
No, sir.
Anyone has any question, or we will be ending up the session, guys.
No, sir. Thank you, sir. No questions,
Okay,
sir.
guys. Okay, guys, study well and have a very nice evening. I think no one has a question, so we will be concluding the session here, and I'm gonna see you next time. Have a very nice day. Bye.
Thank you, sir. Bye.